Nearly every health center in the country has to have an annual single audit. This is a financial audit that unfortunately not many of the pharmacy and 340B staff know anything about. Today on the 340 Banter podcast, Chelsea and I are joined by Michael, who will go over what a single audit is and how it interacts with pharmacy and 340B programs.
So something that happens for FQHCs that is, I guess, less talked about or less understood is the single audit. So your background coming into the 340B world is through financial audits and single audits specifically for health centers. Can you talk to us a little bit about what a single audit is in plain English?
Yeah, and I think when we're saying less understood is probably in the 340B space.
Yes,
Yeah.
sorry,
Right?
yes.
So in the pharmacy world.
Right, yeah. So on the finance side, I think there's going to be a basic understanding of that. So the single audits are required. Currently, I think it's if you have $1 million or more
I believe so.
in government funding. I think when I started, it was $500,000. And then in 2014, it turned to 750. And I want to say it was like 2024 is when it switched up to $1 million. But if you receive over $1 million in federal funding, then you're required to have a single audit. And the name single audit, it is kind of doesn't make a lot of sense. It sounds sounds very simple, right? Like there's one thing we're auditing. And my old mentor, Terry Horn, had always said it really should be called a dual audit because you're not only auditing the financial statements, you're also auditing compliance and operations. And not only does the accounting look right, but are we actually facilitating this program in the way that the government expects us to? And so that's kind of like a unique thing, I think, from the outside is.
Does it happen annually, like by grant period?
It is annual. It's for your fiscal year, which changes per the health center.
Yeah.
Everyone has their own fiscal year.
And it's an independent audit, so it's not something you can do internally, right?
Correct. So you have to have an independent CPA perform the audit, somebody who's accredited, holds some credentials to do a single audit. So you have to have, I remember at the audit firm every couple of years, we actually had to be peer reviewed to be able to do the single audits, and they'd come and test our files, ensure that we have all the appropriate documentation and those sorts of things. So very interesting, gave me a lot of insights. Again, I didn't start off in pharmacy or 340B, but was doing about 40 single audits a year, facilitating those. And with how much support FQHCs get from their 340B program, I really spent a lot of time figuring out the 340B side and seeing the things that worked, seeing the things that didn't work, and seeing kind of some opportunities to assist health centers around the country.
So what kinds of elements, so I know you talked about the finance and compliance, but what specific elements are reviewed during this single, in parentheses, dual audit?
A lot of things, pretty much everything that touches your 330 grant, right? So obviously, simple side and just kind of, again, I haven't done this in a while, right? So I'm going to leave things out. There's going to be things there that, may have changed a little bit.
Yeah.
But like one big one is grant draws. So anytime a health center goes to pull out of their 330 grant, you have to spend the money before you can draw that money, right? And so we need to test that, make sure that was done appropriately, that it's documented, and that it was drawn for the right grant. So you have these like sub grants that get rolled up into your 330 grant for things like quality improvement or for different metrics that they want to have.
Different
mental
programs,
health, diabetes.
So we'd ensure that those are spent accordingly to what they're approved for. Other things is like sliding fee test work. And I would say that was one of the biggest areas where we would find non-compliance.
Okay.
And one of the really interesting things about a single audit is I feel like it is a overall health check for an FQHC specifically, because one, yes, accounting's right, but we're going and checking your policy. You may have the perfect sliding fee policy. Everything might be checked off.
Is everyone doing it right?
But the question is it being facilitated appropriately, right? And so that's like a big area in which we'd find some non-compliance. And the interesting thing, and I can only speak on FQs, but I'd assume this is relevant kind of anywhere, is non-compliance was never because someone, not never, but rarely is because someone had ill intentions.
Yeah.
It's not willful
Right.
non-compliance.
It's not that people are trying to. It's just that there's gaps in what is being set up and what is being facilitated.
Yep.
And I think a single audit, it gives insight into whether or not leadership has filled those gaps and ensured that operations and finance and compliance are all working together as a team. And if you see someone that's not doing well on single audits, it's not that they don't know how to do their job, it's that they need to work on the system itself.
And I would think that the communication, and you mentioned the team, is a big part of that, because it requires not just the finance department, but it requires ops and the clinical teams doing what they need to do to maintain that grant compliance in order to do well in that single audit. It's not just one department that is ensuring success.
And that translates really to the 340B program kind of at large, the way that we see, everything comes back to policies and procedures. And a lot of times covered entities will take the templates, because everybody and their mother out there has a 340B program policy and procedure template. And a lot of covered entities have taken them, filled in the blanks with their covered entity name, and kind of just set those and let them be, but they don't necessarily reflect what's actually happening within the health center or the hospital. And there's a really crucial step to make sure that the operations and processes align with what is in the policies and procedures, or the policies and procedures are amended to align with what the practice is, and then build the system around it to make sure that happens consistently. So I think that there's kind of parity there for those that aren't necessarily in the weeds with the financial single audits.
So what elements of the single audit really, I'm sure sliding fee to some extent, even if it's not required, a lot of people do apply the sliding fee to their pharmacy department. What other elements were you seeing in the single audits revolving around pharmacy and 340B?
One of the things from single audits that was a common kind of issue, I think, was tying back what was being reported in the accounting system to the source documents. And so the reason I go to this is, I have to be careful what I say. For in-house pharmacies, there were certain vendors that would give me crazy reports on what revenue was or something like that. And we just knew there was no way, right? And we couldn't trust that system. And so that was a big thing that I can remember. Again, just tying back to source data was really important. Mm-hmm. And I think that, that was a gap that we attempt to fill for our clients when it comes to the contract pharmacies, right? Because there's different avenues of when that revenue is appropriated, right? Whether you're pay upon dispense and the pharmacy owes me money at the time that claim is qualified, or you're pay upon replenishment, where the claim, they don't owe the funds on that agreement until that drug is replenished for them. So I think that is one avenue. And me and you have had several conversations about this, Logan, is the use of funds.
Yeah.
And so, it's an interesting thing because, and I know I've seen you, shout that from the rooftops, is a lot of people try to say the 340B program is broken and that the users have no transparency on what they're using the funds for and all that stuff. But when it comes to health centers, if you are receiving a single audit, mm-hmm. The single auditor is required to make sure that 340B funds that are generated are within scope of the 330 grants. Yep. Because the 330 grant is what is giving them access to being a 340B entity. And so for me, that is a very hard fact that we should be utilizing to say, hey, we're getting our stuff tested. We're making sure that we're complying with the law.
And it's publicly available.
And
along with the UDS reports that are also required as part of the 330 grant, kind of annual reporting on quality metrics and patient population metrics, and again, where your money's being utilized. And I think that there is transparency, particularly for health centers, in these other reporting avenues that maybe have not directly been, reported up through 340B channels, but the transparency and clarity is there.
Yeah, it would honestly be a pretty easy pivot to use that data to show the transparency
advocate.
in the 340B program.
Without additional, administrative burden to pull additional information and report that out. It is, I know, particularly for UDS, that's a big lift every year for health centers. And I'm sure that the single audits are similarly a big lift on gathering all the necessary information and incorporating it or collating it in the right way. But because that's already being done for one or two different reporting mechanisms, being able to leverage that information already, consolidated, collated in that way to be able to report out on 340B program would be an easy way to comply with, transparency asks and regulations, because that's already being done.
And I'm seeing that a lot at the state level. People asking me, what should I say in testimony if there's any 340B transparency bills going through, and really talk about how health centers already have transparency requirements. Let them know, because a lot of state lawmakers, they don't understand that, because we are governed by the federal government, but they don't understand that anyone can go to the federal audit clearinghouse and look up any health center's single audit and see their report. The same with UDS. You can go to HRSA's website and pull up that data for every health center and every lookalike. So it's not even just 330 grantees.
Yeah.
That one also applies to lookalikes. But it's really good to show we're already being transparent. And what we've seen in past Congresses, when there have been bills that have gone through, we've really advocated that if there is transparency language added, it should be in line with what we're already reporting to UDS.
Absolutely.
We're already pulling that data, so don't make it more burdensome on the health centers. Let us provide the information that we're already pulling once a year anyway.
And I think that's a really good point is, we have two avenues that we're already kind of being held accountable on what we're spending our 340B money, UDS and our single audit that's performed. So by states or anybody else coming up with these other systems in which we have to parlay this information, that all costs money. That costs money for the health center. That costs money for the government. And
it takes spend away from, being able to provide patient care for organizations that are already tight on funds.
Absolutely. And we're already complying, we're already being transparent with what we're doing, and we're already spending the money within the scope of our 330 grant. All the things that we're supposed to be doing, we're doing. But just so that you can see line items, we want you to spend an extra $40,000 a year trying to facilitate this.
Yeah.
It just doesn't make a whole lot of sense to continue to build new systems when current systems already have that information, and we can probably make
recreate the wheel.
We could probably make some minor edits to make that give everybody what they want out of the transparency side.
Yeah, I think that's a great point. There are edits made every year to the UDS manual. I know we're pulling it every fall, getting ready for the next year to make sure we have our pieces in place, but some simple edits could make it even meet the needs of regulators, because we want to be transparent. Health centers are... we're proud of what we do with our 340B funds. So, but just to limit the burden, I think is the goal.
Absolutely.
Thank you for listening to 340 Banter. This podcast is produced by Grit and Gravel, your partners in marketing strategy and success.